Welcome to AETCM, the emergency medicine channel. Today we are discussing about ST segment elevation and ST segment depression. However, we will be talking about acute myocardial infarction changes also. So we'll see how to diagnose MI in ECG now. Now we'll see ST segment, P wave, PR segment, QRS complex, ST segment, T wave. Here what you should understand is, if you are taking this as isoelectric line, that PR segment should be taken as isoelectric line. If the ST falls on the same line, it is normal. But if the ST is elevated from the PR segment or depressed from the PR segment, it is abnormal. So we will see ST elevation and ST depression here itself. P wave, PR segment, QRS complex, ST segment is elevated here. So that is abnormal. P wave, PR segment, QRS complex, ST is depressed here. So both are abnormal, whether it is ST elevation or ST depression, both are abnormal. Now we will see what is myocardial infarction. Myocardial infarction means this is the coronary artery. Normally when you become aged, there will be plaque formation that contains fibrins, platelets, cholesterol that may partly block the artery. Due to some reason, this may break from here and this will propagate, this thrombus will propagate and it can acutely block the coronaries. So the blood supply to that part of the muscles may be completely blocked. When it is completely blocked, the patient will get severe chest pain that will not be relieved by rest or sorbitate. Whereas it is partly blocked when the patient is doing some exercise or exerted or anxiety, the patient can have acute chest pain, but on rest it can be relieved. So the main difference between unstable angina and acute myocardial infarction is, unstable angina, there is an obstruction, it can be relieved by rest or sublingual nitrate. Whereas in acute myocardial infarction, there is a complete block in the coronary artery, patient will have severe chest pain, it will not be relieved by nitrates or rest. We will see what is acute myocardial infarction changes in the ECG. So for that, you should understand how the leads are categorized in your ECG. You know that it is a 12 lead ECG. There are limb leads, there are chest leads. Chest leads are like V1, V2, V3, V4, V5, V6. They are chest leads. 2, 3 AVF are inferior leads. 1 AVL is lateral leads. So any change in these leads will be confined to that area. Suppose it is V1, V2, it is septal leads. V1, V2, V3, V4 is anterior leads. So changes in V1, V2 is septal changes. V3, V4, V5 is anterior leads. So anteroseptal means V1, V2, V3, V4, V5. If V4, V5 also involved, it is anterolateral involvement. 1 AVL again lateral leads, 2, 3 AVF is inferior leads. Now we will see what is acute myocardial infarction changes in ECG. So whenever there is a complete block in the coronaries like this, patient will have severe chest pain during that period. Even if you advise rest or sublingual sorbitate, the pain will not be relieved. Patient will have severe left-sided chest pain, it may radiate to left hand. When we are taking ECG, initially ECG may not show any change, because acute myocardial infarction, when the patient come to ER and we are taking an ECG, it may show as normal ECG, but after some times again patient will have continuous pain. If you repeat an ECG, first you will see the commonest finding will be very tall T waves. So hyperacute MI can have very tall T waves. Very tall T waves are a classical finding seen in hyperacute MI. That means somebody come with severe chest pain we are taking an ECG, we are seeing only very tall T waves in V1, V2, V3, V4. We have to think about hyperacute myocardial infarction. So if you wait some more time, you can see the next set of changes. So very tall T waves always indicates hyperacute MI. Now we'll see the ST segment, what happens. So P wave is there, PR interval is there, that is an isoelectric line. QRS complex is there. Then you can see there is ST elevation, then tall T waves. So T wave is also tall, ST segment is elevated. If the ST segment is elevated in V1, V2, V3, V4, that is an androseptal MI. So patient is coming with severe chest pain, we are taking an ECG, we are seeing ST elevation in V1, V2, V3, V4, it is called as androseptal MI, androseptal myocardial infarction. So ST elevation in V1, V2, V3, V4 is androseptal myocardial infarction. If you see the inferior leads at same time, when there is an anterior myocardial infarction, you can get ST depression in V1, V2, V3, you can get ST depression in lead 2, lead 3 and AVF. This is called as reciprocal changes. Same like that, when you are getting an inferior wall MI, patient can have ST elevation in lead 2, lead 3, AVF. He can get ST depression in V1, V2, V3. This is called as reciprocal changes. So we have a patient who is having acute chest pain. When we are taking ECG, there is ST elevation in V1, V2, V3, V4. It is acute androseptal myocardial infarction. Suppose we have ST elevation V1, V2, V3, V4, V5, V6 also, and one AVL, we can tell it is extensive androseptal androlateral MI. You can sometimes have reciprocal changes in lead 2, lead 3 and AVF. That is called as reciprocal changes. Suppose you have a patient who is having acute chest pain, and if you are taking ECG and you are getting ST elevation lead 2, lead 3 and AVF, this is acute inferior wall myocardial infarction. Whatever it is, an ST elevation, PR segment, ST segment elevation more than 1 small square. So 1 small square if we are getting, and if it is more than 2 consecutive leads like V1, V2 or V2, V3 or V4, V5 or 2 and 3 or 3 and AVF, they are continuous leads. If you are getting at least 1 millivolt or 1 small square ST elevation which is seen in 2 contiguous leads, then you can make a diagnosis of acute myocardial infarction. So for example, suppose somebody is coming with severe chest pain, we are taking an ECG, we are getting lead 2 and lead 3 ST elevation, then that we can diagnose it as acute myocardial infarction in the inferior leads. Lead 2 and 3 is elevated. Now how do you diagnose it in emergency room? When we have somebody is having severe chest pain, we are taking an ECG and we are seeing ST elevation V2, V3. And then we have to ask myocardial enzymes. We can ask for CKMB and TROP-I. If they are elevated, then it is myocardial infarction. For example, somebody is having severe chest pain, but he had a past history of myocardial infarction. ST segment is persistently elevated for some times. You can get in LV aneurysm, you can get in V1, V2, V3 and all. ST elevation can persist even after an MI. So if he is coming with chest pain, unfortunately this ST elevation in the previous episode was persisting. If you want to know whether the patient is having myocardial infarction or not, you can ask for troponin I and CKMB. They are not elevated, then it is not an acute MI, it's a previous change. So whenever it is like that, whenever you have ST elevation in the ECG and troponin I and CKMB is elevated, then only we can make a complete diagnosis of myocardial infarction. Now, one more thing we have to understand is, when you are splitting myocardial infarction by ECG, there are two important types of myocardial infarction: ST elevation MI and non-ST elevation MI. That means in an ECG, if you are seeing ST elevation and tropi and CKMB is elevated, it is myocardial infarction. We can call it as ST elevation MI. But in some patients, you don't see ST elevation. Instead, you can see P wave, QRS complex. You get deeply inverted T waves. But patient is having severe chest pain. When we are asking for tropi and CKMB, if it is elevated, then you can call it as non-ST elevation MI. So we have two types of myocardial infarction. One is ST elevation MI, another one is non-ST elevation MI. Whatever it is, it's a complete block of the coronaries and elevation in the cardiac enzymes. So ST elevation MI, non-ST elevation MI. In acute phase, sometimes you can get only very tall T waves, that is hyperacute tall T waves. There also it is due to MI only. There are different causes for tall T waves that we will discuss afterwards. So MI means mostly it is ST elevation more than 1 millivolt or 1 small square in the leads to at least 2 consecutive leads. If it is in the anterior leads, we can call it as anterior wall MI. If it is in the inferior leads, we can call it as inferior wall MI. So that is about ST elevation. But in some patients, we have discussed that ST depression can be there. Somebody come with severe chest pain, ECG shows ST depression, and when we are asking for cardiac enzymes, they are negative. So troponin I is not elevated, CKMB is not elevated, then it is mostly unstable angina. So ST elevation indicates acute myocardial infarction. There are differential diagnoses for that we'll be discussing afterwards. So ST elevation with chest pain with elevation in the tropi or CKMB, it is acute ST elevation MI. Chest pain, ST is not elevated, deeply inverted T waves, there is elevation in the cardiac enzyme, that is non-ST elevation myocardial infarction. If the patient is having ST depression, T wave inversion, cardiac enzymes are not elevated, severe chest pain, then it is unstable angina. Whatever it is, when the cardiac enzymes are elevated, whatever may be the ECG changes we have discussed here, if the patient is having elevated cardiac enzymes, then that should be taken as acute MI. If it is not, patient is having not having elevation in the cardiac enzyme, then it is mostly unstable angina. One more type of MI is that we have discussed about ST elevation MI, non-ST elevation MI. Third one is acute left bundle branch block. If the patient is having acute left bundle branch block with chest pain, if the cardiac enzymes are elevated, then that also should be taken as acute MI. So we have discussed about acute MI changes here. But one more thing we have to discuss, that after an MI, if you are thrombolizing properly or if you are taking the patient for a angioplasty, if that part is completely survived, then there may not be much changes in the ECG. But we are unable to thrombolize the patient or we are unable to give proper treatment during acute phase, then ECG may develop Q wave. So normally you can get a very small Q wave in many leads, but a deeply inverted Q wave more than 25% of the following QRS complex, or a wide Q wave more than one division, then you have to suspect it is a significant Q wave. For example, somebody had a chest pain 2 days back. Now we are taking an ECG, we are seeing significant Q waves in lead 2, lead 3 and AVF, then that is a infarcted area in the that ECG shows there is a post-infarction change in the ECG. That means complete necrosis has occurred. That part is dead. That part of the myocardium is dead. That's why we are getting a significant negative wave there. So a significant Q wave is a significant negative window where there is no viable myocardium or myocardium in that part is dead. So whenever we have a patient who is having acute chest pain, if you thrombolize properly or if you treat properly with angioplasty, that Q wave will not happen. But patient who is having diabetes, who can develop silent myocardial infarction, or patient who had not received proper treatment during acute phase of MI, you can get significant Q wave. Significant Q wave means a Q wave which is more than 25% of the following R wave. That means negative complex is more than 25% of the following positive wave, then it is significant. Or if it is wider also, you can think that it is significant. Whatever it is, clinical features are very, very important. This type of patients had myocardial infarction in the past and that Q wave is persisting. And in some patients who after myocardial infarction, the ST segment can persistently elevate. Normally within 48 hours and all, this ST segment will come down. But if it is ST elevation, it is persistently, if it is ST segment is elevated, then we have to think about ventricular aneurysms. So these are the common changes we get in myocardial infarction. So myocardial infarction means acute block in the coronaries. So that part of the myocardium is completely cut off from the blood supply. It is not getting oxygen. Patient can have severe left-sided chest pain. It may radiate to the left upper limb. Patient have sweating, palpitation, hypotension and all. And the pain will not be relieved with rest or sublingual nitrates. If you are taking an ECG, you can get either ST elevation or deeply inverted T waves, but you can get a elevated cardiac enzymes. So CKMB and troponin I will be elevated. If the changes are in anterior leads V1, V2, then V1, V2, V3, V4, it is androseptal MI. If the changes are in the inferior leads like 2, 3 AVF, then it is inferior wall MI. Whatever it is, when there is an ST elevation in the anterior leads, there will be ST depression in the inferior leads. Like that, if there is an ST elevation in the inferior leads, you can get reciprocal changes in the anterior leads. Some patients can have, depending on the arteries are involved, some patients can have hypotension, bradycardia, especially in the inferior wall MI. So ultimately, when the patient present with MI, it is very important to make a diagnosis from the ECG itself. If the ECG does not show any change during acute phase, you can repeat the ECG after 15 minutes or half an hour. But cardiac enzymes are very, very important. Symptomatic treatment should be tried. If the patient is having hypoxemia, oxygen should be started. If there is no hypoxemia, oxygen can produce some adverse effects in that condition. You can give sublingual sorbitrate, you can give NTG infusion, you can give propped up position, you can advise propped up position. Lasix may be required in patients who is having pulmonary edema. NIV can be tried in patients who is having pulmonary edema. If the patient is having diagnosed to have acute myocardial infarction, thrombolysis is the best treatment, can be given in most of the centers. If the patient is admitted to a tertiary care center where PCI is possible, then angioplasty will be the best treatment. Thank you.